more guests than it looks like, because people watch on other channels, and of course it'll be recorded for others. So please bear with us and thank you. Okay, let's begin. Good morning, good afternoon, good evening to all the friends who are joining us, and a huge thank you and welcome to our panel as well. Big thank you to Nikos and Anna for, again, helping set this up. It's my pleasure to welcome Giorgio Palandri and Madoka Nakajima. It's been an honor, really. It was a dream for me to have a webinar on this subject, because when I first met Japanese colleagues and Madoka on the International Hydrocephalus Society and realized what they do in terms of how well they manage NPH in Japan, there's so many lessons to learn from our Japanese colleagues in so many areas. So it's an absolute honor. Giorgio is one of the CSF core members and one of the really true experts in this field, who's been very, very helpful and supportive in developing the CSF section. And I cannot thank you, Giorgio, enough. Thank you, Giorgio, and joining in from Bologna in Italy. God bless you. Madoka, a huge welcome to you. I should say, Dr. Madoka Nakajima-san. It's an absolute honor. Madoka has joined us from Tokyo. He's an associate professor from Juntendo University and has a particular interest in management of normal pressure hydrocephalus, particularly expertise with the use of lumbar peritoneal shunts, which is something that we in the Western Hemisphere, and perhaps even Southern Hemisphere, do not do much of. And we're going to look into these perhaps no justifiable reasons, and maybe more cultural reasons why this variation has happened. And I, for one, welcome the greater use, the more common use of this technique for helping our patients with NPH. So huge welcome to you both, and we'll put some questions to at the end, Madoka, possibly during the presentation. And may I remind the people joining, our friends, that welcome to put your questions in the Q&A section, so we can put them to Madoka and Giorgio. And welcome to you all again. Giorgio, I'll hand over to yourself for now. Thank you.
Thank you very much, Mansour. It has been a pleasure for me to be in the CSF section. And it is also a pleasure for me to introduce our attendees to Professor Madoka Nakajima. He is a respected authority in the field of neurosurgery, and he is specializing in LP shunts. And with a wealth of experience and expertise, he has made significant contributions to advancing this surgical procedure. LP shunting is a technique used to address the INPH, and Professor Nakajima has dedicated his career to refining the procedure, focusing on improving patient outcomes and minimizing complications. Through his research and clinical practice, Professor Nakajima has explored various aspects of LP shunts, including patient selection, surgical techniques, and post-op care. His innovative approaches have enhanced highly the safety and the effectiveness of the procedure to the benefit of countless patients. Professor Nakajima's expertise extends beyond his surgical skills. He is a prolific author. He is publishing his findings in reputable scientific journals, and he is sharing his knowledge through presentation at academic conferences and lectures. His contributions have garnered recognition with the medical community and have solidified his reputation as a leading authority in LP shunts. He is known for his compassionate approach to the patient care, and is dedicated to improve the lives of individuals suffering from INPH. His commitment, his expertise, and passion make him an invaluable asset in the field of neurosurgery, inspiring and guiding fellow professionals in the pursuit of excellence. So we are very honored, Madoka, to have you here, and please show us your presentation.
Thank you, Giorgio. Good afternoon, everyone. I'm Madoka Nakajima from Juntendo University, Tokyo, Japan. So thank you for inviting me to this webinar. So I'm very honored with the opportunity. So I will do my best. Today, I will talk about lumboperitoneal shunt. I have no COI to disclose. So there are two types of hydrocephalus, communicating and non-communicating between ventricles and subarachnoid space. So of course, we have to choose an appropriate shunt method according to the type of hydrocephalus. In case of non-communicating, LP shunt is not used. The VP shunt can be applied for any type of hydrocephalus. Therefore, VP shunt is established as a gold standard and widely accepted with a lot of evidence. According to the National Administrative Database, between 2007 and 2017, and 3/4 of INPH patients in United States were treated with VP shunt, while only 1/4 were treated with LP shunt. However, according to a nationwide hospital-based survey 2012 in Japan, more than half of INPH patients were treated with LP shunt. So LP shunt has accumulated already a very good background. The technique is simple and easy as an extension technique of the lumbar puncture. We can perform it without general anesthesia, and the post-operative scars are small and not visible outside crosses. The most important merit is no intervention to the brain. So less invasive approach is preferred in any surgical field, same as a shunt surgery. The ventricular catheter placement is associated with a roughly 1% risk of symptomatic intraparenchymal hematoma. The slide shows delayed ICH after ventricular puncture. This is irreversible complication. The patients are more willing to accept lumbar surgery than cranial surgery. In previous report, the LP shunt has not generally been favored by neurosurgeons because of high failure rate and the possibility of symptomatic overdosage compared to VP shunt. So is there evidence that really substantiates such fact? So we review the literature for LP shunt to clarify the appropriate outcomes. So Giorgio and his team have a wonderful report. A systematic review and meta-analysis of the literature demonstrated that there was no difference in outcome between the surgical methods. There were no difference in revision rate between the two groups. But the LP shunt was found to have a lower infection and mortality rate than the VP shunt. However, from the 4 reports that cited results from the LP shunt, 3 were from Japan, and 2 of them were from our institution. So the result may not be unbiased. According to a national administrative database, a length of hospital stay is shorter with LP shunt compared with VP shunt. That made the LP shunt is increasingly being used in Japan and surpassed the VP shunt use. This is why more than 80% of NPH patients at our hospital received LP shunts. So today's I will present some points that can make you re-explore this option as LP shunt treatment. So I will talk on these items. I've already told you about the background. The beginning of LP shunt. So CSF play a dual role. For managed intracranial pressure, we expected therapeutic effect of idiopathic intracranial hypertension. For promote CSF production and absorption, we expected therapeutic effect on INPH. The development history. To begin with, LP shunt have a long history. There were different historical attempts until reaching the present solution. The Ferguson 1898 for the first time connect the subarachnoid space with abdominal cavity using a silver wire passing through a hole drilled on the vertebral lamina. The Cushing 1926 reported 12 cases undergoing the shunting using the silver-coated shunt tube. Matheson made uterostomy connecting it with a plastic tube from the vertebral canal. Nevertheless, due to obvious folding, rupture, and obstruction of the shunt tube, the plastic tube and LP shunt were indeed abandoned. With the improvement of the shunt tube materials, as well as the emergence of the shunt device, equipped with a bulb, the usage of the LP shunt gradually became widespread. In addition, these LP shunt placements were performed by the open method of the vertebral arch resection. Then Sherman Hakim first identified the INPH syndrome in 1957. Then the Spetzler and Kuana performed simple percutaneous LP shunt using the silicone tube instead of the other plastic material to avoid these complications. Has not been frequently used in some part of the world. The technique has been often misunderstood for effectiveness and avoided as surgeons were not familiar with it. One reason is that there is no reported standardized technique, and procedure is considered to be complicated. So the surgical technique of LP shunt, I would like to show you our LP shunt technique. So I will describe the 4 necessary stages of LP shunt treatment. The step 0, indication and contraindication. These were the general indication and contraindication that were applied. The good patency of spinal subarachnoid space has to be confirmed. A simple algorithm of indication and contraindication in hydrocephalus treatment. It is contraindicated for non-communicating hydrocephalus. LP shunt should also be avoided if there are brain malformation in the posterior cranial fossa and in the cervical, craniocervical vertebral junction, And it's the case of Chiari malformation, vaginal impression, and syringomie area. So if MRI showed the severe narrowing of the spinal arachnoid space following the inflammation in the subarachnoid space or owing to degenerative disease of the spine. So LP shunt would eventually block CSF flow, risking myelopathy or the underdrainage. However, this is not an absolute contraindication. On this pathophysiological background, the LP shunt can be applied in INPH once adequate communicating between CSF space is ascertained. So I will show you our surgical video.
Maduka, we can't see the video at the moment. Oh, now we can. Thank you. Maduka, we're just seeing the slide with a small picture of the video, which is repeating in the corner. Okay, now we can see a video. Thank you. Feel free to comment if you like, Maduka. Welcome. Thank you, Nakajima-san.
Madoka, if you want, you can also comment the video while we are watching it.
I'm sure the audience can ask questions later. This is fine, as you wish. Thank you. That's good. I really like the retractors you've got in the wound there. Looks like a mini Sugita retractor, but in the lumbar region. Yeah. Very good. I think that's the end of the video. Is that Maruka? Oh, okay. Thank you.
Sorry.
No, this is fine. Thank you. Feel free to comment as you wish. I know there will be a lot of questions, certainly from Giorgio and I, and I'm sure the audience, more importantly.
Okay. This movie is finished. So some useful tips for LP shunt. First, inserting the caster into the appropriate position. So second, place the bulb straight and not deeper than 1 centimeter under the skin to facilitate the shunt pressure setting. Third, placement of abdominal caster. Avoid dead space to prevent caster migration. So usual difficulty with LP shunt is the proper placement of the caster in the spinal subarachnoid space. The paramedian approach is used to target the inferior edge of the spinous process from the medial side of the intervertebral joint from 1 vertebral level below. And advantage of the paramedian approach is the easier placement of the caster into the spinal subarachnoid space compared to the median approach. If the puncture was done blindly, 60% of entries were higher than the intended location. So we try to place the caster along the midline of the spinal subarachnoid space assisted by a guide-wired catheter under the fluoroscope guidelines. This method allows even inexperienced surgeons to easily place the catheter in the correct position. So we try to ultrasound guidance for LP, improve the success rate to decrease the needle redirection and traumatic tap. When static ultrasound guidance is used, visualization of the spinous process is the key element to mark the needle insertion site. When real-time ultrasound guidance is used, the needle is inserted under the direct visualization using the paramedian approach. It is also possible to avoid complication when the catheter tip is misplaced into the subdural space. After lumbar catheter insertion, the flow of CSF tend to decrease and stop after a few minutes of discharge. And insertion deeper or pull out little does not improve the flow. So when subdural, so extra arachnoidal placement is suspected. The catheter position is close to the spinal canal wall. Contrast medium can be injected through the catheter for verification. The pooling in the epiarachnoid space prevent the contrast from mixing with CSF. Contrast washout was poor, and the cauda structure could not be confirmed. After repositioning, the contrast CSF is relatively uniform, and the cauda structure can be seen. So advantage and disadvantage of LP versus VP shunts. We have stated that the LP shunt has a great advantage and that it is not invasive to the brain. However, I believe there are other positive and negative aspects to LP shunt. So negative, higher incidence of symptoms due to overdrainage, and more shunt malfunction due to tube occlusion. The positive easy to predict post-operative outcome from the TAP test. So LP shunt are considered to have many complications due to overdrainage, and in favor of programmable pressure valve and a siphon guard system used in combination. So in EU, U-shaped connector can be used as an integral part. So nevertheless, there have been cases of complications. So he was operated with a Celtus valve and gravity valve attached, post-operatively improving, and the valve setting were level 2 at discharge. On a regular follow-up 3 weeks later, clinically with clearly a persisting improvement. His CT showed big subdural effusion. This required an immediate raise of valve setting to level 4. On his next regular follow-up about a month later, his condition has slightly impaired mainly his speech and cognition. There was a light latent hemiparesis, and the CT showed a big left temporal chronic subdural hematoma. So valve was immediately closed level 8. And the bowel surgery on the left side was performed with immediate clinical improvement. In the immediate post-operative period, we start with high pressure setting for all cases, considering the existence of CSF leakage to the extradural space. When there is a sign of low CSF pressure, such as headache, we check the head CT with careful attention to bed rest level. We lower setting by 2-3 centimeter H2O at a time by referring to high convexity south side. The target setting is determined by the weight and height of the patient. The follow-up for LP shunt. So check catheter position by taking lumbar X-ray. Check the current pressure setting at the outpatient clinic, considering the possibility of accidental pressure change. When there is a suspicion of shunt failure, it is effective to check the shunt patency by puncture the reservoir with a 27G needle. So we believe that such postoperative management can prevent many of complications and improve LP shunt outcome. So let's move on to perspective for the management of INPH with LP shunt. In the future, postoperative management method may be upgraded with telemetric pressure monitoring in LP shunt. So this report demonstrated its effectiveness in idiopathic intracranial hypertension patient. It is also important to note that the intracranial pressure can vary even within the same shunt valve pressure setting. Usually, IAP increases as BMI increases. The patient with higher BMI has higher IAP, as shown in the slide. It seems to me that we must do more to take into account the shunt setting and also the patient's activity status as well. We recently reported the result of an analysis of Japanese symphony study in patient with MMEC score of 26 or less. The result also showed that tap test assessment accuracy reflect cognitive function prognosis after LP shunt treatment. Tap test can sensitively predict improvement in post-operative MMC score following LP shunt intervention. This may be due to the fact that both LP shunt and tap test use similar patterns of cerebrospinal fluid drainage. Therefore, I recommend the LP shunt as the first-line treatment of INPH. So in conclusion, in the diagnosis and treatment of hydrocephalus, it is a prerequisite to ensure that shunting is performed without surgical complications. Because of lack of evidence from the literature on LP shunting technique and standardization among centers, it was not possible to conduct a systematic review to determine the optimal technique. With attention to safe and reliable techniques, we hope that LP shunt will be widely and effectively applied to the patient without any differences in outcome among surgeons and centers. So thank you for your attention.
Thank you very much, Madoka. Truly outstanding presentation. I think that we have some questions from the floor. Vijay Yabalan is asking, I think that you already mentioned this during your presentation. However, he is asking, can you comment on the two valves because you need a gravity valve and a strata valve? Could you explain a little bit more why we need these two valves?
Okay. Yes, this is our institution used the tandem this gravity valve and programmable valve. The LP shunt have many complications for the overdrainage. I think a siphon guard system is needed. So I have another slide. So can I share?
Sure.
Yes. So this is the how to decide it, the setting of the valve. So we considered these intracranial pressure, hydrostatic pressure, intra-abdominal pressure. In the upright position, so the ICP decrease and IAP increase even if there is no shunt. So in shunted condition, hydrostatic pressure, ICP, IAP, and valve setting are balanced. If the valve setting is too high, ICP decrease is insufficient and the symptom may not change. If the valve setting is too low, so excessive lowering the ICP may cause overdrainage complications. So valve setting can be calculated using this formula. But LP shunt lumbar subarachnoid space pressure change due to the shunt effect unknown. This is the CSF drainage. So, however, it is assumed that lumbar subarachnoid space at the tip of the proximal catheter is always under the positive pressure. So, the sit in the position, we can see the CSF. So, although the subarachnoid space pressure decreases slowly due to the drainage effect CSF by LP shunt. So I think we need to do more work on the setting up the programmable valve, considering the siphon guard system. So LP shunt needed these two type, the programmable and siphon guard system. So I'm like gravity valve.
Okay, thank you very much. We have another questions from Ipeleng. Good day. What about the difference between lateral left or right? I mean, regarding the tubing tract.
I like the left side, but it is okay. Some patients have the scar on the left side. I use the right side. So I don't mind the side.
Okay. An anonymous here. Everybody introduce the spinal catheter together with the metallic guide. I think it can be gentle, introduce it, just sliding it without the guide once you pass the tip of the needle and confirm it is going up in the right direction. So if I understand well, and Mansoor, please correct me if I'm wrong, this attendee is suggesting not to go all the way through with the metallic wire, and then just as you are entered the spinal canal, you go ahead with the catheter.
I think so. And as an addition, I mean, I have sympathy with the question in the sense that, and I don't feel it's the main theme here at all, that there is so many ways to put your catheter in. You can do it blindly and it's fine. People do it, a vast majority of people I've worked with and worked for over the years in the UK. And you know, my experiences, a vast majority I've done blindly without X-ray. But then if you use X-ray, do you need to use a guide wire? And if you use a guide wire, the colleagues' anxieties, which we sympathize with, which I think we've discussed before, Maduka and Giorgio, that and I'm not used to ever putting in a guide wire because you worry about the guide wire amongst nerve roots and have not used it before. So perhaps some comments from Maduka in the sense that, do we really need to do that? It's very careful. It's very good, very comprehensive technique you use in Japan, just like so many things, which is I'm in awe of. But please expand on that if it's necessary and how important it is.
Yes, I use the guide wire with the cannula. This is a commercial-based Medtronic lumbar catheter. This is a closed tip. Then insert the guide wire, the catheter into the catheter. Then both we insert the subarachnoid. This is safe. You are worried about the injury, the spinal cord, but this is just 0.45 millimeter. It's very soft and very
very soft tip. Yeah,
soft is not so hard. I don't think injury.
And Maduka, can I ask, is the shunt then fed through the guide wire like the Seldinger technique, like putting in a VA shunt or a venous pressure line? You put the catheter then to follow over the guide wire. Is that right?
Yes.
Yes. Okay.
Yes. You know that just the caster, we can't see the tip. We can see that under the fluoroscope. It's visible into the guide wire. I use very useful. I think this is very useful.
Sure. That's absolutely fine. Please, Giorgio.
Another interesting question. Is there any difference if we direct the thecal catheter caudal rather than cranial? Maybe we do the LP shunting without using any reservoir valve. I think we already discussed this. Okay, so what about if you usually aim in the cranial direction, but what happens if you direct the catheter caudally?
The caudally, some patient complained radicular pain, that the leg pain. I think it's not a good, good way. Caudal to the caudal. This is
okay.
Just the 10 centimeter, 10 or the 15 centimeter up. So if it's long length, it's not good. The drainage for ESF.
Okay.
I think this is a. Usually I insert the L2-3 or 3-4, and 10 or 15 centimeter up to.
Okay.
Okay.
Thank you very much. Another question from Chirag. In young patients with communicating but arrested or compensated hydrocephalus, what is the role of LP shunt? In such patients, do you always consider presence of papilledema as the requirement for shunt?
Yes, if communicating hydrocephalus, we use it, the LP shunt method.
Okay. So you use it not only on IMPH patients, but also on cases of arrested or compensated hydrocephalus.
Compensated. If the third ventricle or the floor, the shift,
the budging of the third ventricle.
I use first of all the ETV the first,
okay.
and the next LP shunt.
Okay. Thank you very much. Yes, this is another anonymous but very interesting questions. Have you noticed any secondary Chiari syndrome?
Kathy?
Chiari syndrome. If you during your clinical observation you noticed after LP shunt tonsil herniation? No.
I've
never experienced.
Okay.
Just a comment about that, maybe, Giorgio. It's in sympathy to people who ask that question around the world. It's something that people get very afraid of, and it was very, very well noticed over the years when it was just simply a tube that would be put in for lumbar peritoneal shunts, particularly in UK and around Europe. And the distal end only offered about 5 centimeters resistance. So when patients stood up, of course, then it was a different kettle of fish. And we used to see it over the years. But with the new valves for lumbar peritoneal shunts, and I'm not putting a plug for Escalap or Mifke and etc. But you know the valves that we use, and that you just don't see that anymore. It's extremely rare. So it's just in sympathy to the questionnaire and in agreement with Madoka and yourself. Sorry.
We know that it is very late for you in the night, Madoka, but I would like to ask you another couple of questions.
Okay.
What is the recovery after LP shunting? Generally, what happens after this procedure to our patient?
Sorry, one more time, please. Deco?
Yes.
Sorry.
I mean, what is the recovery process?
Recovery. Okay. Recovery process.
After the LP shunting.
Yeah, you know that LP shunting is a very minimally invasive surgical procedure. So that we prefer to use the local anesthesia and the spinal anesthesia, the sedation. So the effect of the anesthesia still present for several hours after surgery. The surgery is preferred in the morning, performed in the morning. By evening, the patient is free from the all monitoring and including the IVs, and they enjoying the meal.
Okay.
The next day we started the rehabilitation. So the 1 week after the discharge.
Okay, thank you very much. We have another question from Elizabeth. Do you normally expect changes in the size of the ventricles? I understood it is not always the case. The successful is rather related to the improvement in symptoms.
So my slide the show that not ventricle size, the convexity suicide, we choose the setting the above so pressure. I think there's a ventricle size not so many change after the LP shunt.
Okay, so it's like in VP shunts, we could say.
The different.
Yeah, another question from Theokaris. In your experience, how fast does it work? I mean, when would you typically perform a CT scan to change the opening pressure? Is it as fast as VP shunts or function a little bit slower?
Sure. It is difficult to do question, but I think VP shunt, the LP shunt, and the VA shunt is different. So, okay. Sorry,
do you usually see a clinical improvement immediately after LP shunts, or you think you can wait a little bit longer?
Yeah, this means just after the LP shunt, we think it's the leakage, CSF leakage from the catheter insertion. So it is, I think, the 2-3 weeks the leakage is continue, and after 1 month I set on the valve. And there's maybe 3 months to just the setting. So the VP shunt not so CSF leakage. I think the LP shunt is 3 months after or 6 months after we set in the valve. the good position.
Okay. And what about the first CT scan? When do you usually perform the first CT scan after the operation?
Yes, the next day we check the CT,
Okay.
and 1 week after we check the CT. The 1 month after we check the CT, and 2-3 months after the surgery we check the CT. So after patient come my clinic each 2 or 3 months. So the first year I always check the CT.
Mansoor?
Well, Giorgio Maruca, this is excellent. I wanted to put a question which I feel is perhaps the main one when I speak to British colleagues and European colleagues in the EANS for Maruca, and I'm sure you would sympathize with this, Giorgio. When we are used to putting a VP shunts for a long time, or a particular valve for a long time, you get familiar with that valve, with that setup. And we know the mental gymnastics of shunts is now so interesting, particularly for neurosurgeons. It's much more cerebral now, and more thought process. It can be so much thought process that it can be off-putting, but it's very attractive to many. And my question is around the valve settings to help colleagues around the world if they want to switch to this type of shunt or change. Because some patients don't want to have a hole drilled in their head. Some patients are not fit for a general anesthetic, be good for a regional anesthesia, like in this case, and so on. And before I put my question a bit more accurately, just to paint the picture, when we're standing up, the pressure inside the head is, so most of us we now know is more -5, -6, something like that in the CSF. Sure. When we're lying down, most of us 12, 15, something like that. And of course, it's not one pressure, it's the waveform, which we're very interested in. And of course, when we're standing up, the CSF pressure in the lumbar area or thoracic area, you go from sort of +10 or whatever, from lying down to +40, 50, depending on how tall you are and where you put the tip of your catheter, whether caudal or cranial. So it gets very interesting. And then, of course, you've got the abdominal pressure. And of course, with VP shunt, it's the length and your height, which people should take into account for the setting of the anti-gravitational effect. I guess what I'm saying is you have to look at the mental gymnastics of the VP versus LP shunt, and it's a different mindset. It's a different calculation. For example, in NPH, if you use a B Braun valve, let's say M Blue Plus, you might put the setting for NPH, start off with 8 or 9, and put anti-gravitation device as 30, and then gradually lower it from 8 or 9 to even down to 0, and then anti-gravitational to lower as 25 for someone average height. And you do it incrementally. But those are some good figures, I think reasonable figures. What are your figures and recommendation for valves for the settings? Because this is, I think, what really will help the people who want to use LP shunts. Because some valves you can't put there. You can't, for example, if you put the abdomen, you can't press the programmable, let's say, M Blue Plus valve. And there's more than 170 different valves now, I think, on the market, maybe more internationally. Please share your experience about the valves and the settings. Sorry for the long question, but I wanted to put the setting and give you time. Thank you.
Yeah, it's difficult. Many commercial-based valve there. So the correct answer is that nobody knows. But I think that is necessary, the programmable, and siphon guard system is a best match for the LP shunt, because I use the 0 to 15 centimeter H2O, the gravity valve. The Japanese is not so high as high height, and if the more highest the person, the 0 to 20 centimeter or more, it's compatible. But I don't know. But if and my paper the 2-3 years ago, so with the gravity valve and the programmable valve may may protect the over drainage. So I think it is used for this now the commercial based valve, but in the future, so we need a monitoring system is much better than this system.
Sorry, Maduka, when you say monitoring system,
monitoring system,
like a sensor,
the pressure.
Yes, and as more intelligent shunts come in, you can see the waveform, see the pressure, read it, and have a lot better idea what settings to use and to learn from it for the next patient. But it would be wonderful if perhaps you could share with us later on, you could send it to us, we can put it on the website without plug-in for other people's shunts, if Giorgio, you would agree. What are the kind of recommended hardware or settings that you use? Because when colleagues want to switch to lumbar peritoneal shunt, it's good for them to have an idea what hardware to use, rather than, God forbid, experimenting with a new shunt and then learning from there. If I may say, I don't know what you think, Giorgio, before asking more questions.
Sure, that's a great idea.
Maybe there's other questions. Sorry, Giorgio, that I
no.
Question. That was a very question.
It's completely fine and very welcome. So another question from Elizabeth. Any particular advantages or recommendations using LP shunts in a patient with the new anticoagulants?
Anticoagulants.
Yeah.
Yeah. We sometimes we stop the anticoagulant, but before the shunt, it is not necessary to stop. So because LP shunt is so small scar, it is not necessary to stop the anticoagulant drug.
Are you referring to antiplatelet drug therapy or anticoagulants?
After the shunt? Before the shunt?
Before the shunt.
Yeah, if patient had some other the stroke, they use the anticoagulant drug. We don't stop.
Okay.
That we continue to use the anticoagulant drug.
Okay.
I think this is very important. So we don't want to give a wrong message, but Maduka, if it's things like aspirin and antiplatelet, many people will say that's fine. You can even do a microdiscectomy or routine lumbar operation. I know it's controversial, but there's plenty of evidence that it's safe. Or you can just stop it on the day or whatever. But a lot of people will say be safer, stop it a week before. But when it comes to like rivaroxaban, like non-vitamin K anticoagulants like clopidogrel, strong stuff, would you not say it's better to stop it definitely like a week or 10 days beforehand?
Some patients will do this, but not necessarily. I think I have no experience to the breeding the LP shunt. I think that it is not necessary for stop the anticoagulate.
Okay, I think this is a huge difference between VPVA and LP shunts.
Before VP shunt, I stopped the anticoagulant.
But in sympathy, I think many people perhaps would be right to be cautious when putting in a shunt, whatever shunt, lumbar, ventriculoperitoneal, when you have that period of you're adjusting, because what everyone fears is a hemorrhage, particularly a subdural hemorrhage. If you've got a tiny bleed, that you could make it a lot worse when they've gone back onto something. So it's good to be cautious, perhaps. I don't know what you think, Giorgio and Maduka. Yeah, of course.
A chronic subdural hematoma. The patient have the chronic subdural hematoma. It's better to stop the anticoagulant.
Okay.
But before the shunt, usually I don't stop the anticoagulant. Sorry.
But Giorgio, may I ask a question about why Maduka what you think as well? Why has there been such a variation between perhaps Western or American or European management of NPH in terms of prevalence or use of ventricular peritoneal shunt as opposed to lumbar peritoneal shunts? I wonder, is it is it cultural? Why is it cultural? I remember, for example, a long time ago, my trainees were saying, depended who they trained under in England, whether they used ventricular taps before aneurysm surgery, as you get access to the aneurysm, you want to drop the pressure and drain CSF, as opposed to lumbar drain. Now we're all much closer and interacting a lot more. Why do you think so many more lumbar peritoneal shunts are put in? Because instinctively, I would have thought it's better to put a lumbar peritoneal shunt and not drill a hole in the head. But our familiarity with VP shunt and managing patients makes it so much more easier, certainly in our setting. Please, if you would comment, both of you.
Madoka, your
the patient come in me. I recommended two type of the shunt, the VP, LP. Which do you like? So it is no differences of the outcome. The patient like the LP shunt. I don't know why. So, but the elderly person, the INPH patient is elderly person. They have some disease for lung or cardiac, so the patient is no invasive. They want to choose this method, I think.
Well, I think that your question, Mansoor, is really very, very intriguing. I don't know if there is a correct answer to this, but I must admit, I perform VP and VA shunts. I must say that from my strictly personal point of view, I found that LP shunting is very respectful of the patient. Of course, not having to do with the brain and the risks it carries on. I mean, it's very respectful. How Madoka said at the beginning of the presentation, of course, an hemorrhagic complication is very rare, but it's catastrophic, could be catastrophic to the patient. I must also say that it is difficult, for example, for me to shift to LP shunts since I'm not used to complications of LP shunts. I mean, when you start doing LP shunts, of course, every good surgeon knows that you have also to deal with your own complications. And so you must be taught how to handle complications also. So, I mean, in the future, sorry about that. I hope to have the chance to send one of our residents to Madoka in Tokyo at Shunting Hospital, University and Hospital, and then make them learn from the masters how an LP shunt is to be done and to be followed during time.
Thank you. Welcome.
Thank you, Madoka, and thank you, Giorgio. I think it's perhaps more than one reason, isn't it, that we only do a finite number of operations, and when we do even a large number of a particular operation for a particular condition, it's often our familiarity as a team, particularly as a team, and the backup that perhaps, you know, how we recommend a procedure to a patient. But as one person, I'm only a drop in the ocean. I believe that in a CSF specialty setting, particularly for NPH, it would be very good in the near future in across Europe and the world, really, to be able to offer to the patient both options very well, very well. For example, you know, why I would offer it is if, let's say, they were driving, let's say, which is a rare scenario, then and they don't want to stop for 6 months, then they prefer the LP, then we offer that. But it means that being very, very good and familiar in it as a team in the hospital with both techniques. But I would say that eventually you either get really good at one thing or the other. You get familiar, you either get really good at playing the violin or the piano. Very rare you can do both very well. But I think it's been very, very important for us to learn more from the Japanese experience. And I will join your resident, Giorgio. I will be there even earlier. I thought I could do this operation quite well, but when I watch Madoka doing it in videos, this is really, really nice. So I'll see you in Tokyo soon. Anyway, back to you.
Okay. So thank you very much. I think it's quite time to wrap up this session. And before Mansoor is saying the final words, I would like to thank you very much, Madoka, for being here with us and for answering our questions. Thank you for your excellent presentation. Of course, we hope to see you soon in the future. And I want to remember to our attendees that in Barcelona, we will have the CSF section meeting on Sunday and on Tuesday and Wednesday. Please join us at the ENS Congress. We would like to welcome you in person there.
Thank you, Giorgio. Thank you, Madoka. I'm not sure I want to say much more except a huge thank you to Madoka for joining us and teaching us so much. And we hope actually, Madoka, you come and join us in Barcelona for the big EANS meeting. And the big, reminder to all the audience, we've got a fantastic EANS meeting in Barcelona, which is the annual meeting, and it's a superb venue, as always, but it is even better than I would say perhaps most, starting on the 24th and running to 28th of September this year. And we've got our joint parallel session with the pediatric section, which will happen on the Tuesday, I think 26th of September, and as well as our own parallel session on the Wednesday, 27th of September, with lots of good talks and abstracts being presented. And we're hoping to have a pre-Congress symposium, which will take place, I think, on the Sunday, just before the inauguration of the meeting on the 24th of September. And we'll have a series of talks and some very good case presentations, and hopefully our first CSF section meeting. So a warm welcome and invite to all of you who can attend. And once again, a huge thank you to Giorgio and to Madoka Nakajima-san. Thank you. Thank you. God bless you all. Thank you. And thank you to the whole EANS, Anna and Nikos, for helping us. Thank you, Madoka. Thank you, Georgia.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye-bye.